about how to reduce the Lisfranc joint while you're waiting. We get a lot of open Lisfranc joints. So we have to debride them even if we are waiting. So what I do is I don't have those Chinese finger traps, but I tie the toes with bandages. The medial 3 toes with bandages, and I hang them from an IV stand. Leave it for a minute and a half, your joint reduces. No anesthesia, nothing. Just allow the leg weight to come down. And the reduction is not accurate. It is exactly what you do, and there's no need for anesthesia or whatever. Just let it hang on an IV stand. Try it out one day. Internationally, they've got those Chinese finger traps. We don't have them. I take a bandage, tie the toe, tie this toe, hang it. Talk to people, talk to the patient, take another X-ray or C-arm view. It's reduced after 1.5 minutes. That's a small trick. Anyway, that's not my talk. I'm going to be talking about the midfoot here. But anyway, he talks about that would have gone down very nicely along with this. You want me to change it or should I go along with this? Anyway, so yesterday I talked about the syndesmosis. And So I told you that you don't need to transfix the syndesmosis all the time. And I'll take over from here because now I'm going to be talking about that little small piece of bone which is on the anterolateral aspect of the tibia, which usually gets injured or gets avulsed and is actually a part of the complex syndesmosis injury. And if you look at the anatomy of all of that, this is what it is. So the ligaments, the AITFL is attached to it and hold the fibula to the tibia. That's the anterior part. And then whenever there's a rotational talus injury, this is the ligament which breaks. The posterior one will break when it is the end point, when there's a posterior malleolus or this thing. But originally, this is the one which breaks first. The tibia rotates away, shifts away, and you get this problem. So first point is we have to understand the significance of this. So large series, now we've got retrospective evaluation, out of 250 fractures, this publication from Tim Skeffer's group from Holland, they have found that 25% of them had an avulsion fracture in the front. Could be a Wagstaff, which is an avulsion from the fibula, or more commonly a chaput. Instead of the anterior ligament, there is a fracture there. So the size of this fragment will sort of influence how we manage that. I'm going to show you 2 cases, maybe a third case also, which will look into the various types of fractures, the various mechanisms of trauma, and how we go about it. Just to remind you, this is how you classify them. Yesterday, I talked about the ring of the ankle, which is similar to the ring of the pelvis. You have to get stability. How you get it is different. It's not the implants I'm bothered about. It's the stability which we achieve directly or indirectly. And if you look at the syndesmosis, there's something like you have in the wrist. You have the lesser arc and the greater arcs. Now people are talking about the lesser ring of the syndesmosis. That if we can stabilize it, the whole ankle complex becomes stable. This is just a concept. And that's why we look at the second point, that our concepts have changed. We are now looking at patterns like quadrimalleolar fractures, not trimalleolar fractures. I'm going to give you a case example. This guy fell from a height. And if I ask somebody from the audience, what is this injury? Similar case I showed yesterday. Any volunteer, brave man who's had 2 cups of coffee. Anyway, CT. Some comment on the CT. Guys, anybody who's the panel, anybody? What do you see over here?
The caput fragment is there.
There is.
And posterior lateral fragment.
If you look at the cut, axial cut at the level of the syndesmosis, the fibula which has fractured has gone back with a large posterior malleolar fragment. And instead of the anterior ligament, there is an avulsed fracture of the chaput, which we call the chaput fragment. So all of this is very, very clear. It's what now we call as a quadrimalleolar fracture, because all 4 malleoli are done. So the question is, what do we do now and why do we do it? 6 minutes. So nobody wants to answer me. All 4. I agree. So Dr. Tanna, you see, that's what we say, that the guys who know, they know. So thank you for this, sir. But the key point is, like you do a syndesmosis, we must do a sequential fixation. And we always, like building a house, like Sampath was telling you, get your first tray in position, build the rest of the lateral metatarsals. You have to get the base right. So we put them in a floppy lateral, went from a posterior lateral, fixed the posterior malleolus and the fibula. I mean, reduced, stabilized, and fixed. I don't use the word fixed, reduced, stabilized, and fixed. Then you came to the front, did a small anterolateral approach, and fixed the chaput, because that is reconstructing the so-called syndesmosis insura. And now we assessed the syndesmosis. It was unstable a bit. So in addition to that, we went and did the medial malleolus and put a small a transfixation screw. Now, as we are becoming more confident in our fixations of the chaput, there are some cases where we do not use a transsyndesmotic screw because we've reconstructed the ring. But these were few years ago, 3-4 years ago, and we were still understanding this concept of this. And that's why when there is a significant fragment over there, that's the message. You must identify the instability, identify the fragments which are causing the instability, and stabilize them. And the first thing you always do is get the fibula and posterior malleolus into place. And when the chaput fragment is small, you may be wise to transfix the fibula to the tibia after it is all in a reduced position, because then you can't malreduce it by a syndesmotic screw. What do we do when there is a comminution of the chaput? Look at this case. Anybody wants to give comments? I'll show you the CT scan. You can see right there. So much comminution of this. But you don't see, there's a small medial malleolar fracture here. And probably that's it over there. Look at the CT scans. The depression of the distal tibia and the maximum instability is at the chaput's level, because if you look at it, in addition to the chaput fragment, the fibula has shifted anterior. So probably there is a posterior injury also, which you have to address. So you have to look at this through appropriate surgical approaches. We did a simple medial fixation, small avulsed fragment, it was there. So we opened it up, we put in K-wires, and instead of a tension band wiring, we used fiber tape to hold it in place, which is almost the same thing over there. And then you open the chaput fragment, you can see the large fragment over there, but it was comminuted and we couldn't put screws through them. So we did an indirect method. We took these plates and we buttressed it in place after making that stability. And then, because we had not actually fixed this, we used a syndesmotic screw as an additional stabilizing device. So that's what we did. And once we reconstituted the ring, this is what happens, and the patient has a good outcome. So despite comminution, despite not being able to put a screw through the chaput, that's what happened over there. So the key message which I've got to give you is that we are now recognizing the importance of the chaput fracture in ankle injuries. And there are many of them. The data published show that there are so many of them. And if you stabilize them, please understand, I'm changing my word from fixing. If you stabilize them, you can put a screw, you can put a plate, you can put a secure anchor. Whichever ones are fixed, most of them would have good outcome. And the other follow-up is that out of 50, if you stabilize the chaput, only 9 needed a syndesmotic screw, because that was because after stabilization there was residual instability. That is what I am trying to say. Another point before I finish is, I'll end with another case, is you can stabilize the chaput indirectly. Like you can stabilize the syndesmosis indirectly, you can stabilize the chaput indirectly. One way is to put in a syndesmotic screw in a reduced fragment if it is small enough. And this is a case example. This is a disrupted ankle. No, bad ankle, high ER injury with a big fracture, tail has gone back. And as I said yesterday, all our ankles with displacement and swelling get put into an external fixation. So you don't get trouble reducing them and fixing them when you're doing it after a few days. They all get an external fixator. The talus comes back into place. The malleoli may or may not come back into place. And here you see that small chaput fragment over it. It may be too small to do anything. So what we did here is fixed everything. And by an indirect method, the chaput falls into place, but then it is unstable. Even if it doesn't feel unstable, please put in a syndesmotic screw in this case, because that will hold the chaput in place. Okay? So there's this thing about if you're going to put so many incisions, what are the approaches? It's very, very simple. It depends upon which quadrant you are addressing, and you can do any one of these approaches. They will help you. And the gap between these is enough for you not to cause any damage over there. So folks, take-home message is very simple. Understand the injury mechanics, understand the anatomy, and plan appropriately. Because unless you get the CT scan, and as Sampath told you, in the ankle you can get away with the conventional scan. The lower you get, you have to tilt the angle of the CT scan. And we must also start thinking of this so-called quadrimalleolar complex concept of stabilizing the ring. We must reconstitute the ring. And why we are now focusing on the chaput is because it's part of the incisura. So if you stabilize the incisura, let's say with a screw, you cannot get a mal-reduced syndesmosis, even if you put in a screw after that. The reduction of the syndesmosis is ensured by a posterior and an anterior malleolus fixation. So you should plan surgical approaches with care, and both the direct and indirect methods work as long as you've got adequate stimulus. Thank you so much for your time.